All right, we'll get going. So my name is Matt Calvia. I'm the Director of Nursing Practice and Professional Development at Oregon Nurses Association, and we're going to go over House Bill 2697, which is now the hospital staffing law in the state of Oregon. So we have made it through the legislative process, and it is now law. So this is our ONA. We use our collective power to advocate for nursing and quality healthcare and healthy communities, and we most certainly did that in getting this bill passed into law. So this afternoon, we're going to go through kind of an overview of the new staffing law and some of the components in it. We're going to look at the implementation timelines and what we can look forward to, and then some next steps for members across the state. And we'll save some time for some question and answer period. If you can put questions in the Q&A function in Zoom, and then we have moderators who will be able to look at those and compile them for the Q&A section at the end of this. And we're also going to collect these and put them into an FAQ document, which we have one started. It is on the ONA website. So by all means, visit the website and you can read in more detail about the law and see some of those FAQs. So House Bill 2697 has become law. The Oregon revised statutes have not been updated on the Oregon Health Authority page yet, but that will be coming soon. And OHA will also need to engage in some rulemaking around some components of the law. And ONA will be closely involved with that. We'll have members and staff involved, and then we'll also be doing outreach to members for making public comment as that process goes forward with the rulemaking. I just need to flag that this law is the product of union coalition work. We had SEIU, ONA, OFNHP at the table negotiating with the hospitals. And also we had a lot of support from AFSCME, and then all members from all of these unions are going to benefit from this law. And this is also a huge product of the election work that occurred in November. So getting our elected officials into the legislature, getting Tina Kotek elected governor, these were all really big steps in getting this law passed. And it would not have happened if we had not done the work back in November and then through the legislative session. It is remarkable, this law. It establishes RN to patient ratios in statute, which that's the first time this has happened in the nation. California they established it in the rulemaking process, and we now have these codified in statute. We've also added CNA ratios. And then this is also, when it comes to the nurse to patient ratios, it's RN to patient ratios. And if a hospital looks to use like LPNs, then there has to be some work with the staffing committee. And we'll discuss that more as we go through this presentation. This is a law that's going to be a standard across the country. Other states are already contacting us, talking about it. There's federal legislation that looks, somewhat similar. And I think this would be a real, our HB 2697 would be a very good reference point if we do look at federal legislation. So once again, ONA has led the way for nurses and other healthcare professionals across the nation so that we can make sure that our patients are getting high quality care. A big part of the law is it establishes new staffing committees for not just nurses, but service, technical, and professional healthcare workers. So we have now in hospitals in Oregon, wall-to-wall hospital staffing committees. So those are in the bill. If you were to read the bill, it's in sections 3 and 4. And they explain how these new committees will function, which is somewhat how the nurse staffing committees were functioning before the ratios came into effect. And we still do keep our nurse staffing committees, and they still have a huge role in this, but we've established those baseline ratios from which we can build. So the delineation of how these technical, professional, and service staffing committees will be set, the professions are defined by the National Labor Relations Board. Technical professions like radiology technicians and professional profession staff like physical therapists, occupational therapists would be the pros and tech committee. And then the service staff would encompass food service, environmental service workers, sterile processing, and they'll have their own committee as well. The committees will consist of equal numbers of hospital management and direct care staff, just like our nursing nurse staff committees have for years. And they will have equal numbers that will be able to vote on staffing plans. The staffing committees will develop plans that must take into account the hospital census, the size and layout of the hospital, national standards, and ensuring that patient care needs can be met. And then when a staffing plan is passed in these committees, the hospital must implement the plan and follow the plan, the approved plans, or they would face penalties. The difference where the service and technical folks goes when there is a disputed plan, and we'll talk further about what happens in the nurse staffing committees with disputed plans. But in these service, technical, and professional committees, they have a process to try to work through if there's impasse, whereas the direct care members and management reach impasse on voting to approve a plan. They will continue to do work for, I think, 60 days, and then the plan would be sent to the hospital CEO or their designee for the final determination of the plan. So if the committee is stuck at impasse for a prolonged period of time, the way that this law is written is that the hospital CEO will then make the final determination after looking at all of the minutes and the opposing plans and where the differences are. After plans are completed for these groups, they will be sent to the Oregon Health Authority, who will keep the plans on file. And then further, with all of these new staffing committees, under Section 5 of this bill, staffing committees can combine if all the staff are under the have collective bargaining agreements. So all of the representatives in the staffing committees and the unions agree that they would combine. And this was put in there because the hospitals expressed some of the administrative burden of having multiple committees and did want a possibility of having one large combined committee. But again, that requires approval of all the unions representing the workers before that can happen. So on to the nurse RN to patient staffing ratios. Like I said before, this is the first law in the country that actually codifies these ratios in statute. This is in Section 6 of the law. So again, if you look at the draft or the bill now, you would see this under Section 6, and then it will get its own part in the statute. So this graphic that you're looking at, it breaks down the units and their statutory ratios. So in the emergency department for a trauma patient, it's 1-to-1. And then in labor and delivery, an active laboring patient is 1-to-1, as well as in procedural units. For ICU, non-laboring patients in labor and delivery, and PACU, it's 1-to-2. For step-down intermediate care units, it's 1-to-3. And then it's 1-to-4 for telemetry, oncology. It's 1-to-4 couplet for postpartum units. And then we do know that this is outside of the A1 standards, but the hospitals were pretty effective in scaring the legislators that codifying A1 standards in law could result in fewer services for Oregonians. So I think this is where there's going to have to be a lot of discussion about sticking to professional association standards and guidance. And then Med-Surg will start off as 1-to-5, but in June of 2026 it tightens to 1-to-4. And then emergency department non-trauma is 1-to-4 as well, and we're going to do a little bit more discussion around the ED process in a couple more slides. And then finally, CNAs get ratios, and that is 1-to-7 during days and 1-to-11 on night shift. These may be coming into effect before other components of the law, and so now is the time for staffing committees and looking at staffing plans to consider. We know that there is a shortage of CNAs out there, and most of our units do not get a full complement of CNAs on their shifts. And so this is a good time for unit-based committees and staffing committees to proactively start addressing how are we going to allocate CNAs appropriately on these units so that they fall within these ratios and patients can get the best care that they need. So another part of this law, we close the meal and break loopholes that hospitals have been exploiting for years, and the statutory ratios must be maintained at all times. That is even during meal and rest breaks. So this effectively ends the buddy break system. There is the possibility, the only scenario where it would work is if 2 nurses had small assignments they could combine and still meet that statutory ratio, but it'll no longer be the situation where you're doubling your patient assignment and going way outside of what the normal patient assignment is for breaks. Another good big component on this is that we have protections for charge nurses, because we all know that management thinks the charge nurse can do everything and anything while also running the unit during a shift. So for this reason, we really fought hard to get language in there that prevents hospitals from giving charge nurses assignments in units that have 10 or more beds. So, or maybe more than 10 beds, so maybe 10 or fewer. I'd have to look exactly at that language. But essentially, you cannot make a charge nurse take an assignment when they have in a unit that has more than 10 beds, and that includes meal and rest breaks. So there is a provision in the law that says that if the staffing committee approves a plan that allows the charge nurse to take an assignment, then that can occur, but that requires a majority vote of the staffing committee. So that would require that all direct care members of a nurse staffing committee approve it. So I think we have a lot of safeguards there. We think this is big, seeing what charge nurses have been going through over the last few years. More and more just kind of falls on them. And then as hospitals have been held accountable to meals and breaks, somewhat held accountable over the past several years, we also see that it just comes to, oh, the charge nurse can provide breaks. And I recently saw an SRDF from a hospital. It was a medical unit, which was a busy medical unit. And the manager replied to the SRDF saying that a charge nurse should be able to provide breaks for 5 or 6 nurses on the unit on night shift, each one of those nurses having 5 to 6 patients. And when you do the math, that's not a realistic expectation. That's well over half of the charge nurse shift, just providing meal and rest breaks. So we've created some safeguards around that. Hopefully that'll help the work environment so the charge nurses can work on keeping the unit functioning, mentoring newer nurses, helping out with patients who are decompensating. So ONA members who work in Oregon's emergency departments know that EDs are unique and complicated, and as such, so are the ratios for the emergency departments in the statute. So we know that across the state, the standard is typically 1 RN to 3 patients in emergency departments. And that is what we wrote in the original draft of the bill, and through the negotiation process with the hospitals and legislators, we had to start to make some movement there. There was a lot of concern from legislators that in hearing from the hospitals and believing what they were saying, that this would really back up emergency departments, and they were able to instill a lot of fear. So what we came to is the standard ratio of 1 to 4 patients in the ED, and that is averaged over a shift. And at no time can a nurse have more than 5 patients. So that does not mean that the standard is 1 to 5. It is that at no time, if a nurse does have 5, then another nurse or that nurse for an equal amount of time on that shift would only be able to have 3 patients. And then one-to-one traumas are not included in that calculation. So this one is something that will be going to the Oregon Health Authority for rulemaking. So there will be more details coming out about that. And this is where getting emergency department nurses to make public comment and participate in that rulemaking process is going to be important. And we'll go forward. I think when we look at things like once a patient goes through triage and we hear the stories of nurses who are doing triage, having 30+ patients in the waiting room who have had labs drawn, who've had EKGs, we've accepted that as an assignment. And so I think that is going to need to be in that calculation as well. And that's where we're going to be having to go through the process of rulemaking and working on getting this tighter. Another area that is a little bit different, but did not get ratios at all, was behavioral health units or psychiatry units, psychiatric units. What we got there is that the behavioral health unit will create a multidisciplinary subcommittee consisting of different staff members in that unit. So medical social workers, behavioral health technicians, anybody working in the unit who provides direct care. And that subcommittee will be considered its own staffing committee and will adopt a plan that shall be approved by the staffing committee for the hospital. This was another one where the hospitals were very effective in instilling fear in our legislators and legislators, and you can see that here in the news around the state hospital and whatnot. There's a lot of concern with access to mental health services in the state, and then we believe, talking with our union affiliates who represent some of the other workers, that we can come up with some really productive plans going forward with behavioral health units. And that'll be a multidisciplinary coordination. And we have organized non-nurses at Unity Center are organizing, and so I think we have a lot of opportunity to do work together there. And then we have units and conditions that do not have statutory ratios. So in the law, we have called out ICU patients with particular circumstances. So we didn't define what those circumstances are, but staffing committee will have to approve plans around patients who are on ECMO or CRRT or who have an LVAD or Impella in. Likewise, in the ER, staffing committees will have to approve plans that have some specificity around critical patients in the ED. So those that come in shock, having a stroke or acute MI, those are going to get called out in the staffing plans, and adjustments would be made. So this is where we're going to really need engagement from that unit-based committee structure and staffing committee structure to really point out what these patients are going to need. Further, we have critical access hospitals who utilize swing beds, so non-acute care patients that come in to use these beds. There is a call out in the law so that the staffing committee can approve deviations from the statutory ratios to accommodate these patients, but that has to be, again, approved by the staffing committee. There's no unilateral ability of management to make this happen, to deviate from the ratios. There's also a call out for patients who are facing discharge issues. So we know that there's a skilled nursing facility, long-term care shortage. And so a lot of the hospitals are sitting on patients who no longer need acute care, but are stuck in the hospital due to struggles with discharge. So the staffing committee can approve plans that deviate from those statutory ratios to accommodate those patients. And then finally, units that do not have statutory ratios can put ratios in their staffing plans that will be approved by the staffing committee and then must be implemented by the hospital. So these are your short stay units, infusion clinics, endoscopy labs, and whatnot. Those places they can codify specific ratios in their staffing plans. And then when they are devising those staffing plans, the criteria are they must be consistent with nationally recognized standards or benchmarks. They should have a tool that measures patient acuity and intensity that has been calibrated to that unit. And then they also have to consider specialized qualifications and competencies of the staff on the unit, historic acuity and intensity of the patients on the unit, and ensuring patient access to care. So those are conditions that have always been in our staffing law, and they're reinforced here when we're looking at units that do not have statutory ratios. Another part of the law is that there can be innovative care models that do not adhere to the statutory ratios. Again, these must be approved by the full staffing committee. And what it says in there is that you cannot exceed 50% of non-RN staff. So if a unit wants to start having more LPNs on the unit that cannot exceed 50%, and the staffing committee can approve a plan that would count LPNs in those ratios. And then that model must be reapproved by the staffing committee every 2 years. So it does not go on forever. The staffing committee would review it and then reapprove if it was working. And if not, they could not reapprove it, and it would go back to the statutory RN to patient ratios. So when the staffing committees are creating staffing plans for units or situations that do not have the statutory ratios, we now have a faster and binding process for resolution when the committees reach impasse. And this has been a huge issue across the state. What we saw since the 2015 staffing law was passed and went into effect is that management was able to just kind of obstruct the process. They could be an impasse, and the result was that the status quo was maintained. Now, when there's impasse, we have a really clear process. The process before was getting OHA involved in mediation, and that never had a good result in the very few times it happened. This new law has clear timelines and a clear process that when a staffing committee reaches impasse, either one of the co-chairs declares that a 60-day period begins because they've reached impasse. And in that 60 days, the committee needs to keep working on developing a staffing plan. If after the 60 days occurs and there is no staffing plan, by a majority vote of the staffing committee, they can extend another 60 days. But if the staffing committee does not extend, then we go to the next step. If they extend 60 days and go the other 60 days and still at impasse, then we go on to the arbitration process. And this process is defined in the law. And the parties, both parties, management and direct care, will select an arbitrator, and that arbitration will be scheduled within 30 calendar days. And then the co-chairs from management and direct care will submit the contested staffing plans, the opposing plans or the opposing components of the plans to the arbitrator, who will then review them and make a decision on which one that the hospital has to implement. So this is a huge move compared to what we had before, which required, a very long time to get to a non-binding process. And we never saw it effectively used in the few facilities that were even able to get to mediation. And now we have this very clear process defined with clear timelines. After the arbitrator makes the decision, they'll issue it within 60 days, and then the hospital will have to implement. There are some allowable deviations from staffing plans and statutory ratios. So each hospital unit can deviate from a nurse staffing plan, except for breaks, no more than 6 times in a rolling 30-day period. So they get a few freebies in this rolling 30-day period. And then after that, they are not allowed any more deviations, and they can be fined repeatedly for deviations for each separate violation. If they do deviate, the unit manager must notify the hospital staffing committee no later than 10 days after the deviation. So the staffing committee can keep track of this, and then your union representatives can keep track as well. And then every subsequent deviation during the 30-day period is a separate violation. So multiple complaints could continue to be filed. And then type A and B rural hospitals can be granted a 2-year variance from the statutory ratios, but this first must be approved by the hospital nurse staffing committee, and then it would go to OHA, who would grant that variance. So again, nothing gets through by unilateral decision of management. It all must go through that staffing committee. So when they have the deviations and we see violations of the law, then we begin the complaint process. So we have done away with the triennial survey process that OHA was doing since 2017, where they would do a third of Oregon's hospitals every year. So every 3 years, hospitals would get surveyed. And what we saw on that is a lot of citations. OHA would issue a lot of citations. We would have an extended period in which the hospital would be drafting a plan of correction, and that extended period could go well beyond a year. And then OHA would visit years later, find that the hospital had not implemented the plan of correction, and issue more citations, but there was never any civil penalties leveled. And then OHA was so far behind on surveys that they became farther behind on complaints and revisits, and it was just this compounding problem. So we have done away with the survey process, and it is just a complaint-driven process. So a member files a complaint, and then it sets into the enforcement process where valid complaints must be investigated and whatnot. But one of the caveats is complaints must be filed within 60 days of the violation. The hospitals wanted this so that they could correct their violations rapidly. So if a nurse sees a violation or experiences one, they need to file that complaint within 60 days. The complaints are anonymous. And then another new component of the law, which is huge, is that the union can file complaints on behalf of a member. So we had tried doing that in the past. There was nothing in law that prohibited us from doing it, but OHA said that they would not take complaints filed by the union. And so now they have to. It is in the law that they have to, that the union can file on behalf of the members. OHA has 30 days to open an investigation on a valid complaint, and then they have 80 days to conclude the investigation and provide a written report. So after a complaint investigation, if it is found that the hospital violated the staffing law, then we get into the enforcement process, which is primarily civil penalties. There was a nurse staffing advisory board meeting earlier this year, and one of the direct care members on that advisory board was asking the Oregon Health Authority, and this was before House Bill 2697 had passed, and the direct care nurse on that committee was asking the Oregon Health Authority, well, why haven't you enforced the law? And the Oregon Health Authority replied, enforcement means different things to different people, and we believe we have been enforcing the law. Well, this new law clarifies what enforcement is and doesn't allow OHA to continue having a belief that they're enforcing the law when indeed they were not. So now hospitals will face civil monetary penalties for violations. If they can prove that they can be exempt from the fines if they can prove that they had staffed to the staffing plan, and then if they needed more staff, that they had sought volunteers to work extra, sought per diem staff, tried to get contracted staff from a temp agency, they may be able to avoid the civil monetary penalties. But they have a high bar starting with showing that they were staffed up for the unit, that they weren't chronically short-staffed, or that they, are staffing fewer than their typical census. And then if the hospital is leveled penalties, here they are. So while we've had a staffing law since 2001, it was fortified in 2015, and we've always had civil penalties since 2015 on the books, OHA's never leveled them. And so now we have, if there's an offense with this is, I'll talk about meals and breaks next, but for violations around, like, say, statutory ratios. So for the first offense, the hospital will get a warning. The second offense will be $1,750. Third offense, $2,500. And then fourth offense and beyond is $5,000. So as the offenses stack up, it becomes more expensive for hospitals. And I think the public face of them getting fined will carry a lot of weight as well. And then for missed meals and breaks, this is really a powerful part of the law, is that if you miss a meal and break, you can file a complaint, and that will, if the complaint is found valid, you would receive, the penalty would be the employer would have to give you $200. If no collective bargaining agreement, it says up to $1,000 from Foley. So a lot of collective bargaining agreements are getting penalties in there if you miss a meal or break. And then now there's also the process of filing a complaint. I believe this is going through the rulemaking process as well, so it isn't solely solidified, but you would file through OHA, it would go to the Bureau of Labor and Industry to investigate. They would determine that the employer is at fault, and the employer would then have to pay the employee that $200 penalty. So as far as implementation timeline, this bill takes effect on September 1st. And that is when the agencies can begin rulemaking. So OHA and BOLI will begin rulemaking at that time. And they have a deadline to have rulemaking completed by December 31st. And in that time frame, there's opportunity for public comment, for members of the public to watch the rulemaking process and review the minutes and stay attuned to what is going on. I think that's very important for nurses to do, to see how this process works and to stay engaged. And then right now there's a little bit of discrepancy in how to interpret the topic, but for the the labor side of things, we read that the CNA ratios begin on September 1st. So that is why I was saying earlier, it's a good time to be having that dialogue in staffing committee, unit-based committee on what that's going to look like on September 1st. Then on January 1st, 2024, that's the deadline for the rules to be adopted on how to receive complaints, as well as the, I believe, the ED ratio averaging. On June 1st, 2024, that is when the nurse to patient ratios take effect. So hospitals must be staffing to these statutory ratios at that time. December 31st, 2024 is the deadline for the new staffing committees. So that would be the pros, techs, and service workers to have their staffing committees developed, up and running. That is by the end of 2024. June 1st, 2025 is when enforcement with civil monetary penalties begins. So when the ratios go into effect in 2024 until 2025, the hospitals will not receive a civil monetary penalty for deviations. And then on June 1st, 2025, they can start receiving those penalties that we had discussed in the previous slide. And then in June 1st of 2026 is when the medical surgical ratio tightens to 1:4. And that is all med-surg units in a hospital, so orthopedic and neuro units. All of those neuro units are captured under that med-surg umbrella. So as far as those next steps, what's coming up really quick is that rulemaking, and that is going to be an important process, again, to really define how OHA is going to enforce certain components and interpret certain components of the law. Another big part coming up is on that slide around behavioral health, having the multidisciplinary teams. That organizing work is going to be a priority to start getting that going with those other disciplines to really establish what a comprehensive quality behavioral health unit staffing plan will look like. And then another thing for all members should be familiarizing yourself with the law. We have the ONA website. It's being updated with frequently asked questions and parts about the law, summaries, and then also you can read the actual text of the bill that is passed. I think that's important to really start to build that understanding. We know that we have seen in the past some hospital managers that try to distort it, and so it's important that everybody is familiar with that law. So visit the ONA website, and also visit the Oregon Health Authority website. They are the regulatory agency for most of this, and they are updating that website as well. They have some updates there from the recent Nurse Staffing Advisory Board presentation they gave. They have made some statements where they're unsure of what, how they're going to be going forward. So it's important that nurses are paying attention to that as well, nurses and other healthcare professionals. In your individual bargaining units, it's important to be engaged with your unit-based committee. If you have vacancies on the committee, get those filled. Pay attention to what is being discussed there. This work starts at the grassroots level, unit by unit, and then it rises up to the staffing committee. If you have vacancies on your staffing committee, get those filled. Start thinking about succession plans so that we keep those seats filled with members who are engaged, knowledgeable, and wanting to really make this law work. And likewise, with your PNCC, these are the places where the work really occurs, is members in these committees having those conversations with management and bringing up, our professional association guidance. American Nurses Association published the Principles of Nurse Staffing. That guidance has not gone away. All nurses have to adhere to the Nurse Practice Act. Other healthcare professionals have their rules, and those are the conversations we want to make sure we're having with management throughout implementation. And then ONA will continue holding meetings, forums. We had a staffing committee co-chair meeting last week. I think that is where we get the best conversation, the people doing the work. We know that the CNOs across the state meet regularly, and they're going to be meeting to discuss how they're going to implement this law with minimal impact on their profit margins. And so we need to be coordinating statewide, hearing what each other are going through, sharing strategies so that we can make sure that implementation is to the benefit of nurses and the patients that we care for and all of the other healthcare professionals impacted by this law. So with that, I think we can move on to questions. I will stop sharing. And do we have any questions that I can try to answer?
We do. We have a few questions, and I imagine they'll keep rolling in. The first one is, in our department, we have a 3-to-1 nurse-patient ratio. If the law recommends staffing 4-to-1, will this end up being our ratio? And then mentioning also this ratio may be in the contract.
So
3-to-1 or 3-to-1, yeah.
Yeah, so this law, but nowhere does it say this is the recommended ratio. This is the floor. So this is the ratio. If a hospital deviates from it, it's at the point where they could face a penalty. So there's no reason that you would have to, like, the hospital would be able to make an argument that, oh, now we must adhere and give you an extra patient. We all still have to answer to the Nurse Practice Act. We have to make sure that we can provide safe, competent care. And the historical acuity patient population that you're dealing with, that is what determines staffing. The ratios in law are the floor from which we build. So the hospital could avoid maybe a civil monetary penalty if they deviate, but nowhere in the law does it say this is the ratio that the hospital must adhere to. This is the floor. It's kind of like minimum wage, right? There's minimum wage laws, but we aren't making minimum wage in the hospital.
All right, the next one is, will care management ratios be included?
Care management does not have ratios included. And this has been a tricky part even with the existing law. So OHA has interpreted it that, are you providing direct care, and then they kind of give it a may. You may not need a staffing plan. So like IV therapy, they consider, and RN care management, some of those they consider these roving professionals that they don't accept the assignment. They're like a consult, and therefore may not need any kind of staffing plan or ratio. And that is not different in this law. It doesn't call it anything specific for RN care management.
So I'm going to break the rules. I'm going to hop down because there's kind of a follow-up to that first question that I asked about the ratios being worse than what they currently have. So if managers are already telling nurses things like, well, now that we have the new law, you'll have 5 patients. I think it would be great if ONA makes a quick handout we can share with the direct care nurses specifically related to this issue. So just kind of bringing that further forward.
Yeah, it's unfortunate to hear that managers are doing that. And it's not really defensible. So I think that is where we need that. And absolutely, ONA will be there to help. You also have the ANA principles of nurse staffing. There's a lot to discuss around that. So I think that this is where we need that unit by unit work. So if you have a manager that is saying that needs to be discussed at a unit-based committee or a unit-based meeting. It needs to be captured in a record in minutes. The manager said that historically, because of our patient population, this is how we staff, and now we're going to make that worse. And then that needs to be passed on to the staffing committee and the PNCC and the next layer of managers who may be engaging at that level. And that discussion needs to be happening. We are still professionals. Our managers are professionals, and we have to have these, that is probably a retaliatory statement. I think that's a demonstration of incivility. And we are always going to have bad managers, no matter what law we have on the books. And we're always going to have to address them with some collective action through organizing, communication, and professionalism. And that occurs in these committees. And so it's unfortunate that is happening, and we have been hearing about that, but I don't believe that this law enables them to become bad managers, right? This doesn't give them the ability to do that or to deviate from the standards of being a nurse.
So the next question is about the staffing committee structures moving forward. will CNAs have a vote at the staffing committee now? I think that's the way that the question is written, but I think that also speaks to the potential for changes or what we're looking at as far as what the staffing committee will look like.
So because of the way the NLRB defines those professions, I believe that the CNAs, they may have kind of a component of both parts, but they will definitely be in the service staffing committee. But they will be in nurse staffing plans because of the services they deliver. So I cannot recall, so we'll have to follow up on, and maybe it's in the frequently asked questions if that CNA vote continues on staffing committee. I apologize. I don't know that answer offhand. I believe they stay on the nurse staffing committee as well, but I have to double check.
All right, so the next question is, what is recommended for ED ratios on patients treated in the ED lobby, pit, or triage area?
Yeah, so I think this is a part where there's going to be a lot of discussion in rulemaking. It'll kind of be continuing discussions that happen while negotiating amendments to the bill. So we need to have the Oregon State Board of Nursing come and weigh in. And that I think is, we have had that happen at rulemaking processes in the past when OHA was making rules around the staffing during an emergency in 2022 after the 2021 legislative session. OSBN came in and provided some interpretation. And I think we will have to have that happen in rulemaking, because it is my understanding that that triage nurse accepted an assignment. And nowhere in the law does it say that the ED starts at a certain wall and is beyond this wall and not in the waiting room. That is all the ER. So when you triage a patient, they get labs drawn, they get an EKG done. Now there's follow-up, there's a nursing process, you have to do your assessment. You face liability if like the labs result critical and you're unable to follow up on them. So there's a lot of liability for the nurse. And so I believe that those patients need to be counted in the ratio average. And that is something that will have to be worked out through rule. And maybe it's going to be something that, you know, we have to go through the process of complaints and whatnot to have adjudicated. But if the nurses in triage are liable for those patients, then by all means, they have accepted that is an assignment of patients. And that would fall, you are an ER nurse working in an ER, and that's an assignment. That is my interpretation.
All right, will there be a link sent out so people can file complaints easily?
So that is another part of the rulemaking. OHA is going to have to develop the process for filing a complaint. So for some history, they always have had their complaint process online. It's an online form that's filled and then emailed in. That's always been available. It was just the general OHA complaint form for any complaint for any hospital. So ONA frequently went to OHA and said, we need a nurse staffing specific complaint form. Our members on the Nurse Staffing Advisory Board also brought that up during those meetings. And so OHA did create a nurse staffing complaint form, but that was in addition to the other complaint form. So in true OHA fashion, they made us two forms. But now we know that they're going to have to come up with another process, an online portal. So hopefully they can make it a little bit more functional. But we don't have control over how they do that, but that is going to be part of their process.
Okay, so I'm going to kind of combine the next two questions because I think they're kind of asking the same thing. And it's about the time frame between when the ratios go into effect and when the penalties go into effect. And what will OHA be doing in the meantime? And what can nurses be doing before those penalties are really enforced?
So we don't know what OHA is going to be doing. They gave a presentation a week ago, and and that's what they stated, that they don't know what they're going to be doing. So I think there is work amongst ONA and our union affiliates to have discussions on what OHA is going to be doing and using our influence where possible. And then as far as the work that can be done, there's the staffing plans that you have now are in effect. The staffing plans, if they meet the statutory ratios, they stay in effect. And then if they don't, they have to be adjusted by June of next year. I think this is the opportunity where nurses who, again, and this is why that engagement at that unit-based level and in the staffing committee, PNCC, this is why it's so important, is to start bringing that to management. And we can do it in very in ways that they have weaponized in the past to try to obstruct us. And now we can use some of those conversations and say things like, hey, this law is going into effect and it has very clear timelines. Can you show us your projections on hours per patient day? Can we break those down? Can we sit down in unit-based committee, look at those, and how are we going to meet the law? Are you saying that you don't want to meet the law until the absolute deadline? We as the direct care nurses and our shared governance models want to start moving to meet the law right now. You know, we want to start building. And we need to have them, you know, they use hours per patient day to deny staffing plans all the time. We can't approve that staffing plan because it would cause an increase in hours per patient day. Now we have a law that says they're going to have to increase it. Let's force the transparency to see what that looks like and start having those conversations. The work that we've been doing doesn't stop and it continues. And now we have some different tools that we get to use in that work. And we have more power now in that they are going to come at you. Soon, nurses in units are going to, at their unit-based committees or at their staffing committees, are going to have managers come and say, we need to pass this plan that allows the charge nurse to provide meal and breaks because of our budget. We don't have to do that. And now the difference is, for the last several years, if there was impasse, the status quo stayed. Management got their way. Now, if that doesn't happen, the law stays, and that charge nurse won't take an assignment and won't provide meals and breaks. So we have to start coming from a different angle where we have a lot more power in this. We have a different toolbox. But I think now, well, probably forever, but we always have to be calling them to do their work. Management needs to do that work. Show me the work on how you calculate HPPD. Show me what it looks like our hours per patient day going forward. And then for other professions, same thing is they can start having those conversations about how they're going to set up these staffing committees and what those staffing plans are going to be looking like, and starting to be proactive in that approach.
The next question is about pediatric intensive care and neonatal intensive care ratios. If they're not the same as traditional ICU ratios, how can you help these units on the Nurse Staffing Council?
So the ICU, it encompasses all of the critical care units. So that is the 2-to-1, or 1 RN to 2 patients. And then it does have the component around patients who are who have different needs in ICU specifically in ED. So I think looking at that, you have a cardiac pediatric ICU patient that is probably a condition in which you're looking at the 1-to-1, or maybe it's 2 RNs to 1. So I think critical care is going to have to look at things like that. Massive transfusion protocols. That's not there's just no possible way that one nurse can do that. And getting those things identified in staffing plans is still going to be important. And it has been important, and it continues to be important.
All right. So you mentioned at the beginning of the webinar about the new staffing committees for techs, professional, and services or service folks that are organized with unions. But what about the facilities that those departments are not unionized?
So if those folks are unionized, then the union selects their committee members. If they are not unionized, management facilitates the process in which direct care members are appointed to those committees. The combination of committees, such that like the nurse staffing committee would combine with the others, that would require approval of all unions. And if so, obviously, if ONA is the only union in the House, they're not going to, that it would not behoove us to approve that combination. So that is a discussion on kind of a bargaining unit by bargaining unit, facility by facility basis.
All right, next one should be easy. Will this presentation be available via a shareable link?
I don't know. So I think we are recording it. We need to make sure that one, I didn't totally say something wrong. And then make sure it looks good and that it, you know, people can hear everything well. And then I think the intent would be yes, to share it.
Okay, I didn't pre-read this question, so it's a long one. Regarding the small unit language of 10 beds for charge nurse assignments, can they confirm or modify the language to say 10 occupied beds? So if it's a small unit, we technically have 12 beds for our unit, but 4 overlap and boarding. So if we only have, say, 8 patients, would this current wording make the charge over 8 of 12 potential patients not be able to take an assignment? Did that make sense?
It does. I mean, the
Okay.
statute, the statute says, it does not say patients, it says beds. And I think, you know, part of that is if you have 12 beds and you only have 8 patients and you're a hospital, you may end up with 12 patients throughout the shift. And then the person who usually facilitates getting the patients into the beds and whatnot is the charge nurse. So I believe as the law is written, it says 12 beds, not patients, not occupied beds. And so it would stand that the charge nurse should not or may not take an assignment. Now, if the unit wanted to change that and they could get that approved by the staffing committee, that is the provision in the statute, in the law, that, you know, they could go and a charge nurse could take an assignment if it gets approval from the staffing committee.
Okay, the next one, how was staffing committee impasse resolved prior to this law?
So prior to this law,
Sorry,
go ahead.
how did it happen that the CEO came to be the person who resolves an impasse, as the second part to that question?
So the CEO only resolves that impasse for the service, pro, or tech committees, not the nurse staffing committee. And that, you know, would be a better question for some of the other unions like SEIU. But I believe that language was modeled off of New York, who got similar language before us. And you can look at like the pros, tech, and service worker staffing committees is where the nurse staffing committee was in 2001. Like when that law was passed in 2001 in Oregon, it didn't really have teeth. And so the hospitals did not have to implement staffing plans that went through those committees at that time. There was no real enforcement. And so it has taken, you know, over 20 years for the nurse staffing plan or nurse staffing law to get to where it is. And this is kind of that first part of the process with the pros, techs, and service workers, healthcare workers. And so that was through the negotiation process, you know, with the other unions who represent a lot of those workers participating, and that was the final. That was where that ended. Was the CEO gets that final determination. With the nurse staffing, so prior to this, what the process is now until September was, if you reached impasse at staffing committee, then a co-chair would declare impasse and notify OHA, and then there would be this like period like we have in the new law where they had to work on the staffing plan. And if impasse was still occurring after that, it would go to OHA, who then would provide a mediator, and the mediator would come and in the rare instances where it occurred, and they would mediate between the two parties and come up with kind of a non-binding solution. So I only know of a couple of hospitals where it occurred, and those folks definitely did not see it as a productive process. It took an incredibly, you know, long amount of time to get there. And so this gives us more of an expedited process, and then it has that binding arbitration. So whereas before an OHA mediator may say, this is, you know, what you should do. It did not bind the hospital to do that. And now we have the arbitrator is going to say this is the plan that must be implemented at the facility.
All right, when we look at staffing for the ED, should we look at ENA standards since we know ED patients vary in acuity quickly?
Absolutely. I think that, you know, that's the part that's where we have to kind of keep going back to the ratios in this law are the floor and we build from there. And that these are the levels for which the hospital could face a penalty. We do not abandon our professional obligations and the guidance from professional associations, which are driven by, you know, the members who are professionals in those environments. And so absolutely the ENA standards, you still have staffing plans. This law does not get rid of staffing plans, and you should still be highlighting those in the staffing plans. Like those components should still be there.
All right, inpatient rehabilitation is not stated in the current staffing law. How do we convince admin to include us in the med-surg ratios of 1 to 4?
Good question. So so I guess if that would come to, this would be a unit then that would go to, you would create the staffing plan, it would go to staffing committee. And if the direct care nurses and the management members do not agree on the staffing plan, and direct care is saying it should be 1 to 4, management saying it should be 1 to 6, or whatever, and you reach impasse, then it begins that binding arbitration process. And that is where it comes to again, being professionals, having a really clear, you know, reason, justification of why 1 to 4 is most appropriate with inpatient rehab. And then that would go, so I think if you see that going to an arbitrator, if management is saying, well, the budget does not support that, that is not a very compelling argument compared to, you know, we take care of post-stroke patients who have frequent falls, and we take care of traumatic brain injury patients who are impulsive, and we have a deficit of CNAs at all times. And so it is just not safe or possible to take care of, you know, more than 4 patients.
Okay. The next question is, are CNAs required in every staffing plan, assuming members would pass a plan without them? An example being maybe on night shift in a low acuity area. And then part 2 of the question is, would patient care technicians or non-certified caregivers follow the innovative staffing plan guidelines?
So there's nothing that requires there to be CNAs, and like nothing in this law. And then there is nothing. So one of the things with the registered nurses is to get reimbursed by Medicare, you have to have a registered nurse, and there has to be a care plan and these things. And so that is, you know, we know that registered nurses have to be in the hospitals. There's nothing in the law or in CMS rules around the CNAs. So I don't think we have that. And then, so I don't know how. I think that again is going to be facility by facility, unit by unit, looking at the staffing plans, and it's going to be the same, you know, similar process we've been going through of having that work done. That kind of shared governance, collaborative work to address that with each individual staffing plan. And then the second part of the question was,
would patient care technicians or non-certified caregivers follow an innovative staffing plan guide? I think if you were to use them for an innovative staffing plan, is that okay?
Yeah, so again, this is, the law does not specifically talk about, so a patient care technician is from my understanding, this is an unlicensed assisted personnel. So the law doesn't address unlicensed assisted personnel. Nor does it like exclude them from that provision where you could do the innovative care model. But it does have to pass staffing committee. So there's no unilateral implementation by management. So if they came with a proposal that they want to use patient care technicians and say that an RN, you know, that they can change the statutory ratios based on that, the staffing committee would have to ask a lot of questions like, okay, this is an unlicensed assisted personnel. And according to the Nurse Practice Act, in a facility that requires 24-hour nursing, you cannot delegate or you cannot assign to an unlicensed assisted personnel without significant liability to your RN license, because you would need to be providing direct supervision the whole time they were engaging in that. So I think that is again, that comes down to that. This is why it's important to be engaged at the unit-based and staffing committee level, is these are the discussions. Management's going to try to do things like that. And that's where those discussions come in, is saying, well, why would you put all of the RNs in, potential liability by having unlicensed assisted personnel? That's not appropriate. We're not going to pass that plan.
All right, next question is talking about minimum standards. Does the law still require that 2 licensed caregivers be present when there is 1 patient in the department?
We will have to follow up and put that on the frequently asked questions.
Okay, I got another long one that I haven't quite read through to make sense of yet. So hopefully it makes sense. Let me know if I can help. Where do the monetary penalties go? Which fund? Who gets the money? Do the nurses who actually have to take the extra load write down the assignment is over the staffing ratio or extra patient for X amount of hours on the time logs? Do the nurses actually getting wronged get compensated with these fines? How much is the fine? Will it be broken down per hour per patient? Will this be standardized across the state? And then the actual fine amount. Wanting to know what that is too. So a lot there, and I can reread if you need me to.
Yeah, so with violations that would have to do with the statutory ratios, that is going to go, I believe, to the general fund. It would not go back to the nurse who was impacted. The fines are, for the first offense, it's a warning. The second offense is $1,750. Third offense is $2,500, and then the fourth and subsequent offenses would be $5,000 per offense. Now with the meal and break violations, then the individual would be compensated by the employer. There was more to it. As far as standardization, this is the law for all hospitals across the state. What else am I missing from that one? That was a long one.
I think that pretty much covers what the questions were asking.
Okay.
Yeah.
All right, what section in 2697 is innovative staffing addressed? Thinking of non-CNA techs that Prov has floated over the last few months.
So it is, let me double check. Give me 1 second. And again, so Providence can float it. It would take approval of the staffing committee. So they cannot implement something like that without receiving approval from the staffing committee. And so they don't have that, like, unilateral authority to make that change now. Give me while I keep. Well, we can.
So I just added in the language from section 6.
Section 6, thank you. After section 5, which is, I believe, where the ratios are.
Okay. Does the new staffing law state anything regarding when a nurse needs to take patients as total patient care, meaning no CNA available? My med-surg unit night shift is currently 1 to 6 patients with a CNA and 1 to 4 patients without a CNA.
No, the new law does not address that. But I think, again, those are the conversations at the unit-based level and the staffing committee level. And that's where that work continues, and that's the work that we've been doing. Like you were able to get that in the staffing plan now. That is the same kind of work that got you here is what goes forward.
All right, the next question is about procedural units. Stated earlier that procedural departments are a 1-to-1 ratio, but then that endoscopy units don't have ratios under this law. Is endoscopy considered a procedural area?
Sorry, yes, endoscopy is, but it would be, I was thinking more of the outpatient endoscopy unit that is under the hospital license. So you've got the pre, post, and procedural care. So you have the patient going through a different continuum. So it's more like maybe a short stay, but they're not going to the OR, they go through the procedure. So that is, I was thinking the entire, not just the procedure area of an outpatient endoscopy unit, but the whole process from check-in to discharge. And some of those units fall under a hospital license and are covered under the law. But then we know that there's freestanding endoscopy units that are not under a hospital license, and they do not fall under this law.
All right, so working in the OR, do scrub techs missing breaks also qualify for missed breaks and lunches? My understanding is all healthcare workers.
That's my understanding as well, and they will be in the, so they will have representation in the, I believe in the, I think scrub techs would fall under the scrub tech, the tech and pro staffing committees, and then it is my understanding as well that yes, they would have protections around missed meals and rest breaks.
Are the fines levied per day with an incident, or per day, or per every incident where the caregiver was out of the staffing plan / ratios?
So I don't think we know that one yet. Is our understanding though that the fines would be levied per violation. So you would file a complaint for a violation, and then there would be a complaint investigation. And then that is where the citation and potential civil monetary penalty would come into play. And we're all done.
I don't see any more questions.
All right, good. Well, that it's a little after 5. Appreciate everybody attending, and please spread the word to your colleagues out there that this is law now. It is going into effect soon. Familiarize yourself with it. It is different than what we've had, but there's still a lot of the same work that we'll be doing at that unit-based level. I do see one hand up, and I would need somebody to help me figure out how to get somebody with a hand up.
Sorry, it looks like Virginia Smith, you've got your hand up. So if you could type your question in the Q&A, we can get it. That would be the easiest. Sorry.
We're getting some kudos in the chat, so that's fun.
Oh, yes. Yes. Oh. And yes, Virginia, there will be more ways to engage for sure. Be it webinars or like the meeting that we had last week with co-chairs, which I thought was great. And then I think we need to, kind of keep having these happen as much as possible. All right. With that, I think we are all done. Thank you all so much for attending. We will see you again soon, and looking forward to implementation. Take care.